Awesome. Well, hopefully everybody got some good Korean barbecue or some poke out there and some awesome views. I'm Dr. Clint Flanagan. I've been in direct primary care for a number of years, and we have a network of DPC physicians that's in about 14 states now with over 100 locations. And about 90% of the market that we serve is employers. So the graph that was showed a bit earlier with the, as I've called it, the groundswell of interest in DPC, particularly from employers, is pretty exciting. Really appreciate Hint and all the sponsors that have brought this awesome event together. We're going to have a pretty cool panel. Back when some of us started, there was nothing, we didn't really know, direct specialty care wasn't even a term. And technically, people were thinking that DPC was concierge medicine. So it's fun to be on a stage with physician colleagues and Harry talking about these synergies between direct primary care and direct specialty care. So we're going to take a little bit of time here and just everybody introduce themselves, and then we'll get into the nuggets here.
Hi, I'm Harry. I got really interested in this space when I had a family member who was referred to see a specialist. They were told it was a 6-month wait time. They booked in. About 2 months after that, they ended up in the hospital. And the specialist walked in when they were in the hospital, figured out what it was, having been an infection in my mom's jaw, and she was given antibiotics and was better pretty much immediately. And I kind of started looking into this and realized it happens all the time, where there's this broken referral system that means that people can't get the care they need. So founded Thea Health, where we link PCPs specialists ahead of referral decisions. We have a booth back there, so please come visit if you want to learn more. Then fast forward a bit, we recently got acquired by Hint, which we're really excited about. Over the years have become true believers in DPC movement, as they were our only happy customers. So, really excited to double down on that and have more DPC focused features coming out and things like that too. Right.
All right, thanks. I'm Mike Havig. I'm an orthopedic surgeon. We'll talk about why I went on the journey, I guess, but I was seeing more and more people that just wanted to pay directly for their care, mostly local small business owners, so a lot of the same folks that you all treat as DPC docs. And what I found is a lot of folks who are paying directly for their care, when they want to see a specialist, they get turned away. And it's not really because the doc doesn't want to see them. We all have like a little piece of paper with a self-pay program somewhere in our office, but our staff forgets about it. We do nothing but train them in third-party billing collection. So you might call me and say, Mike, I want to send you this patient. I'd say, yeah, great, no problem. Happy to see him. We'll figure out a cash rate. But when they call the front desk, they get turned away. And so what I did is I realized to make this easier on my staff and my patients and my referring docs, I needed to bundle all my services. So I bundled everything you can do in musculoskeletal, office visits, procedures, injections, physical therapy, imaging, surgeries, and put a reasonable price on all those bundles. And I started presenting them to the general public on my practice website, and just really to solve a problem, and not to really grow my business, but it turned out there's a lot of those folks around, and it grew the business, and then more people wanted to use it. So now I founded a company called HealthMe, where we have about 1,700 orthopedic surgeons on the platform nationwide who offer everything from office visits through surgeries, all transparently priced and bundled, and very simple technology for you all to navigate patients to them and for them to serve your patient population.
So I'm Maryal Concepcion. I'm a full-scope family physician in rural Northern California, up in Arnold by Big Tree State Park. Today, this is amazing, is the 2nd year anniversary of my practice being open. And what a full scope moment, thank you. What a full scope moment that my very first DPC conference was the Hint Summit in San Francisco in 2019. And people like Garrison were opening that conference, and now I'm here being able to share more of my story. I practiced in fee-for-service for about 6 years. The employer who I worked for said, when I was 28 weeks pregnant, you can sign our contract that had exclusivity clauses, rates that were never going to be renegotiated under an evergreen clause, et cetera, or you will be fired in 31 days. And at 28 weeks pregnant, and a physician, a full scope family physician, I said no. You know, hearing Allison speak earlier, we all have our experience in healthcare trauma, and that was very much part of mine. And I remember sitting at 2:45 in the morning, this very pregnant lady saying, how can I let other people know about direct primary care? And so now when I speak about direct primary care, I speak from advocacy and excitement because of my podcast, my DPC story. I love that I have so many abilities to see how the physicians in this movement are really growing it in specialty care as well as primary care. And so I'm super excited to be on this panel because I just heard Dr. Allison Edwards, a lovely physician, who was speaking on a podcast recently about how physicians who are specialists are not choosing this. Here's an example, and here's an example of how that's wrong. So super excited.
Hi. So my name is Nicole Harkin. I am a preventive cardiologist and a clinical lipidologist. Any other lipid geeks in the audience? Anyone? Anyone? I have a practice called Whole Heart Cardiology, which is a direct care cardiology practice in San Francisco. My story is probably pretty similar to many of yours. Practiced for about 5 years in a traditional insurance-based model in New York City, and when I moved to San Francisco in 2020 with my husband for his job, stayed home with the babies for a bit, and then sort of was trying to figure out what was going to be my next step, and I knew it wasn't going to be insurance-based medicine, and frankly started hearing murmurs about DPC and direct care movement, and found a couple other docs that were specialists, and decided to give it a leap of faith and see if I could do it in a specialty sort of care. So happy to say currently thriving and really moving into version 2.0 right now, providing patients with similar high-touch comprehensive care that they really are demanding, and they're happy to engage in my services and not use their insurance, which still continues to surprise me. It's just such a mindset shift, and the types of patients I care for are anywhere from a 45-year-old man who is desperately seeking my help because every man in his family had an MI at 50, and he wants me to help hopefully prevent that from happening, to the guy who called me up after he got discharged from his cabbage and said, I want to enroll in your membership right now because I don't want to ever have this happen again. So that's the type of work I'm doing.
Appreciate the introductions, everybody. So maybe Dr. Maryal, if we could start with you, and maybe you and I can chat with the audience a bit about the status quo and referrals. So as a family medicine physician, let's say in a traditional system, a patient walks in with a PPO plan or a Cigna deductible plan and you want to refer to neurology. Talk about a bit the status quo from both a physician perspective and maybe from a patient perspective too.
So thanks, Clint, for that question. So I grew up in Sacramento, lots of doctors, lots of healthcare options there. I trained in Modesto for residency, definitely a very high Medicaid, Medi-Cal in our state population. And now I live in rural Northern California. There's about 4,000 full-timers in my town. And so picking examples from each of those, locales has really allowed me to see the differences that exist, especially if you're urban or rural, especially if you're insured, uninsured, double insured, gold, platinum insured, whatever it is. Because what I see as a common thread is access to quality specialty care is insanely hard to get, even if you're in Sacramento. I mean, the people who go to UC Davis, who live down the street, they're still waiting 6 months to be seen by dermatology. They're waiting 8 months to be seen by rheumatology. And so I would say access is a huge issue for everybody, no matter where you're at, and we all know that. And then I would say the quality of care is really different when you're dealing with a direct specialty physician versus someone who is on the clock. Like Dr. Mina Julapali, she's a pediatric dermatologist. She said she had like 3 minutes with each patient who had waited 6 to 8 months to see her. And so, yeah, it's like cheering Dr. Julapali on. Love it. So when it comes to the quality of care, very frequently my patients come to me after they've seen their specialist in fee-for-service, and they say, okay, what did that doctor say to me, and what's the plan? And I lovingly take that question in, and I say, great, we are going to address this because you deserve to know what has been talked about with regards to your health care, and also you need to understand what are the solutions, the treatments, the medicines that have been mentioned, so that you can make an informed decision as to whether or not you're okay with that, you need a second opinion or whatever. As a rural family physician, I'm insanely happy to have people like this on stage because, like, I use Thea Health. As a rural doctor, I opened my practice. I opened it as a telemedicine and home visit only practice, but I opened it specifically knowing that I could use a platform like Thea to be able to access specialists, because my patients, where I live now, they minimally have to drive an hour and a half to get to most specialty care places without waiting months and months and months. They're still waiting like 2 to 3 months, but it's better than 8 to 12 months for your colonoscopy. You might be dead by the time you actually have a colonoscopy done, but I can give you options. I had a very amazing experience with a physician who is in, I believe he's in North Carolina, Dr. Sumal Modi. He's a neurologist. My patient was on the docket to wait 8 months to see a neurologist and drive 3 hours to go see the nearest one that would take her insurance in the Bay Area. And I said, how about next Wednesday? It's $185, and we can do the visit together. So I did the exam as directed by the neurologist, and we were able to get her care. So I love, again, that I'm on stage with these people because we're really proving how your quality access to your family physician, internal medicine physician, whoever is seeing you as a physician, paired with the ability to access specialists who are doing this care, it's really bringing the tenets of direct primary care into the world of all physicians. Yeah.
Appreciate those comments, and the point there is the access, the convenience, the cost of seeing a specialist, or even arguably a family medicine physician in the traditional system is very challenging. No matter whether you have a PPO plan or let's say you have a deductible plan like about half of Americans, right? And you go see your primary care physician, they refer you to neurology, you're going to be out of pocket for that cost. You don't know what that cost is going to be. And in Boulder, Colorado, it's 6 months to get in to see neurology. Contrast that with some of the things we're going to talk about on the virtual specialty care side, and we can have answers same day and affect care. So it's affecting the care plan. Oftentimes, as primary care clinicians, we just have a question or 2 or 3 for our specialty colleagues. In the traditional system, we refer out for that question or 2 or 3 that we have, and there's a cost to the patient, there's a cost to the employer financially, but there's also a cost to them medically because it just takes so much time. And if you're a system primary care clinician, oftentimes you see, those clinicians are seeing 25, 35 patients a day. While it's within their scope to take care of diabetes and high blood pressure, et cetera, oftentimes they're not doing that. Not that they can't, it's that they don't have the time. So they're referring to system cardiologists, system neurologists, system endocrinologists. And again, more cost, more time, delaying care. So fortunately, we have some solutions. So I'm curious, Nicole, maybe if you'd comment a bit on what you're seeing in the specialty world as let's say, an innovator and pioneer of stepping away from being paid by Cigna or United.
Yeah, so we are, as specialists, I think certainly still very much in the beginning stages, and certainly inspired, as I said, by all of you. Specialists are similarly, very disillusioned and limited by time and all the things that that you know very well. And so increasingly also looking for solutions. And so I think many of us are. So I'm very active on social media. I will tell you that I get messages almost daily. About, how did you do this? Can you tell me how to set this up? I want to set this up too. So specialists are coming and they want to be doing this as well. And so, and I see that landscape unfolding in a couple of different ways. So, one as standalone places where, we can deliver really, really high quality care, obviously. And then I think that interaction and that relationship between direct specialists and direct primary care is pretty cool. And so I love all of my internal medicine and family medicine colleagues who refer to me, and I pick up the phone and call them after I've seen the patient, and we institute the care plan, and sometimes they don't need to see me again because they'll continue with that plan. So I think that relationship can be very, very powerful, and I think as more and more people start to realize that direct care is sort of the solution, hopefully, to our massive healthcare problem, I think just the better for everybody, patients and physicians alike.
Excellent. Dr. Havig, you've been doing this for quite some time on bundled rates in the orthopedic arena. Can you comment on your experience in, let's say, transitioning from payment from a carrier versus payment directly from a patient or directly from the employer?
Yeah, sure. And just to be clear, I still, in my practice, I think one thing with specialists, I think even primary care, I think when you all decided to go into the DPC world, I mean, that's a big decision, right? You're saying, hey, I'm going to forego insurance payments. That's a big leap. And I think it's the same for specialists, and I think a lot, even more so maybe for specialists, I don't know why, everyone gets their head down, and we're all busy, all doctors, and it's just hard to make people change. So I still have one foot in the regular insurance world and one foot in the direct specialty care world, which I think is a great way to do it, and I think it's a great way to get people on board. So I will tell you that while I started doing this out of really of a necessity to just serve, honestly, my friends, I practice in my hometown, a lot of them are, just self-payers, right? They own small businesses, and even if they can afford insurance, it doesn't make sense for them. And I had to create a solution for them. I realized that it was good business for my practice as well. And I tell people all the time, when I talk to my colleagues, I say these are the best patients that I see. And I think you all would agree, right, when you started doing this? Like, these people are extremely appreciative to have access to specialty care, and not just access, but access for a reasonable price, right? Like, I think everybody thinks it can cost $5,000. I mean, I take my dog to the vet, it costs me $500 or $600, right? And you can see a specialist for a lot less than that. And if it's bundled, where they know they can just show up, they get a visit with the provider, the doctor, or the PA, but usually the doctor in my case. They get x-rays if needed. I'll throw in an injection if they need that. Again, it doesn't cost me much to do that, but I want to serve the patient and take good care of them, and then they go and tell their friends, and it really, these are the best folks that I see, and I wish 100% of my practice actually could be direct specialty care, and I'm getting there. Hopefully I can come back in a couple years and tell you what that's all about. So anyway.
Appreciate those comments. And so obviously there are things that you do that can't be done virtually. Like, I don't know that we're doing total hips or knees yet.
That'd be nice.
But a lot of specialty care can be done virtually. Just like 50 to 70% of primary care can be done virtually, but you don't really see that in the traditional fee-for-service insurance world. Harry, I'd like to have you talk on the e-consult, and let's call it the start and evolution of the e-consult, and what your thoughts are, having a really good finger on the pulse of using specialists in an e-consultative way.
Yeah, so I'd say that it definitely takes some getting used to, but if you look at referrals from in the fee-for-service system, about half of them are unnecessary. And then there's this other bigger chunk that kind of overlaps with this unnecessary group of these referrals that the PCP either was practicing defensive medicine, or they had a quick question, as we kind of mentioned, and they just needed it answered, but instead they send the person out, and it ends up costing that patient $1,000, and takes 6 months to get in and have all these trouble systems. And lucky DPC has an incentive to actually provide a greater scope of the care and help those patients out. And so what we've realized, and others are doing it too, and happy to talk through some of the details on that, but is you can, if you're in your EMR, you can send labs, images, clinical data. We've, even send things you're having from devices and things you're doing in your office. You can, 80% of the time you send one of these consults out, the person doesn't need to go see a specialist. You can retain control of the care, and even when they do, you can then go to that specialist armed with the evidence that this is something that's really serious and need to be seen soon, and it's not going to have a bunch of duplicative work because you've already done the workup and keep control of that patient, which I think is really important. We kind of have a local specialist aspect of this as well, and we found that doing these consults and working with local providers helps them become more like direct specialists because they actually want cash pay, they just don't even know it exists, right? And so if you can be in your community and talk to some of these specialists, you can have this kind of digital front door, but actually it can help you, get back to that collegial, type of medicine that DPC practices with their patient, and hopefully we can keep rebuild those relationships from the primary care specialty as well by doing so. So.
Appreciate that, Harry. And Maryal, as you are very familiar as a physician doing e-consults, can you kind of talk about the process of the e-consult and what that looks like for both you and then the patient?
Yeah, absolutely. So, like you mentioned, we work up as much as we can, especially you and I, we're family physicians. And then there definitely are places where I'm like, my knowledge does not go past this point, and I need to get either a second opinion to make sure that, yes, I'm going down the right pathway, or are there, other things that I could be checking, labs that I'm not sure about, I haven't ever used before. And so for me, I love, even though I'm rural, I can reach out digitally to a lot of people and just say, hey, here's like Harry's saying, here's the CT, here's the echo, here's the labs, here's all of my workup, the patient history. I love that physicians who are online also are not feeling pressured to rush through. And so what I've gotten is very detailed conversations back. I had an amazing talk with a dermatologist from the East Coast. I had an amazing talk with a pulmonologist, cardiologist, because I was wondering what else can I be doing while my patient is waiting to see their physical cardiologist to get their cath done, et cetera. But I just love that the value proposition of my practice explodes when I'm able to offer my level of care as a full scope family physician, as well as bringing in tools like e-consults to be able to offer my patients an even more amazing value proposition where they're like, wait a minute, with my macular degeneration or my fear of crossing the bridge, I don't have to go to these people quite yet. And I can say confidently, yes, I will ask even more than one e-consult physician to be able to say, yes, these are the things that the physician said, these are the things that we could do, how do you feel about that, et cetera, et cetera.
Yeah, I think that's part of the beauty of direct primary care is we have the time. Often we're the quarterbacks of our patients' care, and we have the time to really dive deep with our own level of expertise and doing the things that we can do within our wheelhouse. But then, every once in a while we may have a question or two. And to be able to go onto a platform like Thea or some of the other platforms where there's over 120 specialists and they're at your fingertips, and to be able to send your information, for example, on a patient that has a mental health issue that's quite complex that you've been managing as a doctor for months and months, and you've got a couple of questions. The person may have bipolar and you're wondering about switching meds, and in Boulder, Colorado, you send to psychiatry, and most of the good psychiatrists don't accept insurance anymore, are $300 to $500 an hour, and it takes 4 to 5 months to get in. No, that's the status quo, versus with e-consult, we can get onto these platforms, send that information to the psychiatrist, and have answer back the same day. Change medication the same day for a patient, and the cost for the patient on that front or the employer is $0, right? And then some of the e-consult companies even give us CME, continuing medical education, for doing the consults. So it's just a complete shift from the status quo. Can
I add something to that too?
Yeah, 100%.
I just love also, my husband is a family physician, and he was told earlier in January that his clinic was going to a non-physician model. That does happen in a lot of places. And so when he went to DPC, when he was talking to me about DPC, and he was like, oh, I would run cases with him and say oh, you just refer to cardiology. And I'm like, no, actually, let's rethink that. If you were to approach this without the pressure of time, how could you have done it differently, or how could you address your patient's care differently? So I see also, working with specialists as part of our, in our toolbox to be able to have an e-consult platform, or people like Nicole, who I've talked to about our firefighters locally. It's part of our healing also, because then it allows us to really be able to be full scope doctors. We're able to take the information from specialty care with the patients we know, and then we're able to talk to them about, comprehensively, this is where the suggestion from the specialist comes in. And it's like, there's nothing more rewarding, and that's what we went to medical school to do, is to be these people's doctors. So it's a healing thing too.
100%. And so maybe Nicole and then Mike, if you could give examples of patients that come through your door and A, how they're getting to you, B, a bit of the services that you offer, and then C, maybe in your case, Mike, compare and contrast like a bundled surgical rate for, let's say, a knee or a carpal tunnel, your ASC, versus that same procedure at a system where you've got the day surge and the facility fee, and what those things look like.
Yeah, so I would say that most patients are finding me currently right now word of mouth. So other patients telling other patients, and as well as also a fair amount of social media in the beginning, and then also a good amount of referrals from internists in San Francisco and elsewhere. And people also just now find me on Google as well, which is pretty interesting. And it's what's great about sort of having websites and a digital presence is that patients will really feel very comfortable already. Like they know exactly kind of what type of doctor I am and what they're looking for. Like they know that we're going to probably talk about fiber, and they're going to walk away knowing the exact pathophysiology of how atherosclerosis develops, and that's why it's important that they take their statin. And they like get it, instead of, and like maybe it ends up being the same recommendation, but they're like, I like, we took an hour together. Like I've never had anyone explain it to me in that way. So, so people find me through all those channels really, and then eventually it's just started growing. I've been just overwhelmed and incredibly pleased with just how the response back in terms of how positive it's all been. And so in terms of services, it's I started actually also for more telemedicine for probably that first year as I was sort of testing the market, if you will, and then opened my doors a little over about a year ago, and do consults, EKGs obviously, and sort of embarking on sort of the diagnostics. And I think that's another thing I wanted to bring up that I think will be a value add to this community at some point, hopefully, is also that ability to access cash pay sort of diagnostic testing. And I'm sure you'll talk more about sort of procedures as well. So echoes, stress tests, et cetera, things like that. In my community, the wait is months and months for these kinds of tests. And I actually had a coffee with the chief of a cardiology at one of the big hospitals. And he's like, I can't even get my patients in for a stress test, and I am the chief. So, and he's like, so the ability to access cash pay prices and get people in quickly, I think will be really, hopefully, really a game changer within my community. So.
Yeah, I would say when I started doing this, it was kind of a word of mouth situation also. You see patients and they realize that you're offering great service for a fair price. They tell their friends, and then you get somebody in a sharing ministry that comes and they tell other people in the sharing ministry. And pretty soon it ends up becoming a big part of your business. That being said, to really do this at scale, I think you need to be able to kind of package up a network of specialists, which is what I've done in my other full-time job with HealthMe, is we've built this network, and it's all digitized and it's searchable, and that network can be deployed to a primary care doc to be able to search and create their own little private network with payment rails and everything. So we're trying to make it simple. All the headaches I've seen in my years of doing this, I got referred a patient by a self-insured company, and the patient lives a couple hours away, and I ask for medical records, and it takes me 3 weeks, and I get a giant box, with just a data dump of everything the guy's had at his hospital system, which is pretty worthless for me. I asked to set up a telehealth consult with the patient, and they don't really know what that, they kind of know what it is now, but in the early days, they're like, but pre-COVID, it's like, what do you mean? How do we do that? And whatnot. So a lot of those things have been streamlined by platforms like Thea, and we're trying to streamline the brick and mortar care for specialists. And then I'll close with what you asked about the difference in price. I have personal experience with this. So my son, who's a college student, broke his wrist last year on spring break. He happened to be out of the country and ended up having This is just kind of an interesting contrast. So he's in Switzerland. He didn't get to go abroad during COVID, and so he went with a bunch of his friends. At any rate, he was in Zermatt, powdered his wrist into a million pieces. Ambulance ride, hospital stay for 4 days. He was in the hospital 4 days, kind of old school. Surgery, ER, CAT scans. They scanned his whole body, right? Everything. The bill for that was $13,000, which is pretty reasonable, right? For all that. In the United States, that'd be a $500,000 bill, easily. That being said, I talked to the hand surgeon there, and if you're going to break a bone anywhere other than the U.S., Switzerland is the place to do it because that's where they invented internal fixation. But anyway, this guy said terrible fracture. I worked on it 3 hours, and I hate to say he's going to need more surgery. So came back. He goes to a large university in North Carolina, and I got connected with the hand surgeon there. And I knew it was going to be expensive, right? I have a high deductible. I have a $10,000 deductible, whatever. And I knew it was going to be expensive, but ultimately the bills come in, and for an outpatient open reduction internal fixation of the wrist, and granted, it was a more complex case, but it doesn't matter to the insurance company. They just pay for a CPT code, right? The facility fee for the hospital outpatient surgery center alone was $42,000. And my insurance paid that. After I hit they paid the hospital $42,000. That did not include the surgeon's fee. That did not include anesthesia. That did not include any of the other stuff. It wasn't bundled. That was just facility fee. We sell that. I have clients on HealthMe, orthopedic practices that sell that all day, all in, anesthesia, surgeon, surgery center, implant, 90 days of uncomplicated post-op care, about $8,000, give or take $500, right? And so that is the contrast, a $60,000 episode of care basically versus an $8,000 episode of care, which is kind of more in line with what they do in Switzerland. Even they were a little more expensive than we are. But that was a different situation, obviously. So at any rate, that's why self-insured companies are looking to you for a better solution and looking to us as specialists. And we just got to get more of our colleagues on board, really. So.
Appreciate that, and we're going to have a little bit of time for Q&A, a couple of minutes. But I think the take-home here is obviously you're at a DPC Hint Health conference. Find yourself a direct primary care physician, and if you are a physician, you're not a direct primary care physician. Talk to some of us, and we'll help you out. And then the awesome thing is now we have direct specialty colleagues, orthopedics. In our building in the Boulder area, we have a new modern urology direct pay urologist, right? So urology, cardiology, dermatology, orthopedics, et cetera, et cetera. And not only are you going to get better care at a better time, you're going to get it for a much different cost. And so I think we've got a minute or two here to have a little Q&A. So we'll open it up to the crowd, and happy to answer any questions.
There's one over here.
Go ahead. Who's ever raising their hand?
Thank you. I don't think my mic is on, so I'll just talk louder. I'm a gynecologist, and so I'm interested to find out. I heard about with HealthMe, your bundle packages. Can you guys talk a little bit about how your packages are set up? Are you doing monthly memberships? Are you doing procedure-specific packages? Can you talk a little bit about that?
Yeah, so the packages we built, and we started in orthopedics, that's what I do, and we're moving into other specialties, but what we want to do is bundle the whole care cycle, so I'll point that out. I think everybody focuses on surgeries, which are important, but how does healthcare work now? Patient sees the doctor in the office, they might see their direct primary care doc, then they get referred for an office evaluation, then we might determine whether they need a surgery or a procedure. So we bundle office visits, we bundle in-office procedures, testing, and then ultimately the surgical procedures. So those bundles generally, the surgical procedure bundles generally include the surgeon's fee, the facility fee, and then implants, whatever's needed to take care of the patient. We have the ability to offer a complication insurance on the bundles through a third party we've partnered with. So as a patient or employer, and even a physician, we like to have that safety net, even though it's rarely needed. And then basically the last thing, I think, with a lot of procedure-based specialties like OBGYN or orthopedic surgery, how do we work with our hospitals and surgery centers, right? And how do you get them to buy into this? And it's very difficult. I'll just tell you, I've beat my head against up against that a lot of times. The good news is we've actually got a pretty good process now, and I'd be happy to talk to you about offline. There's some approaches you can take, and I think one of the big things I'll say is if you, quote unquote, own the bundle. I've given talks on physicians owning the bundle. So instead of, I think everyone thinks of it backwards. In my opinion, as a surgeon and a physician, insurance companies and employers like, well, let's identify a hospital and get them to bundle. Let's identify a surgery center and get them to bundle. Let's identify an MRI center and get them to bundle, whatever. How about identifying the person actually providing the care, the doctor, and let them create the bundle? And so what I recommend and what we do is we say, let's build you a bundle. We can give you cost data on the facility, and then you go back to your hospital or surgery center and say, hey, how about if I give you 150% of Medicare to do this procedure? And they'll say, yeah, sure. If you go to them and say, hey, will you do a bundle with me? They'll be like, what are you talking about? We have no idea. And one last comment I'll make, the hospitals do not like pricing transparency. They get paid the $50,000. So they're not going to be like, what, are you crazy? We don't want our name affiliated with that. But here's what they will do. If you own the bundle, they'll say, well, we have a bundle with Dr. I'm sorry, I didn't catch your name. But we have a bundle with Dr. Havig, and Dr. Havig's doing this bundle for X, and I've negotiated in the back end with the hospital. The hospital loves that because they're just like, oh, we work with Dr. Havig on that, right? And so it kind of obfuscates their transparent pricing, which is sad that that's what it is, but it is. So.
Well, we really appreciate everybody's time. We could spend another hour or two, but we're like the CU Buffs in double overtime right now. So thank you, panelists. We're going to be around, and feel free to grab us for questions.